basically here is an acronym for radius, exophytic, endophytic. Near is the collecting system of the sinus, measured in millimeters, anterior or posterior location of the tumor, and L stands for location related to the polar lines. So there's a score of 1 to 3 is assigned to each, and the total of that gives us the nephrometric score. Basically, it's shown that nephrometric score can predict the operative approach of the urologist. For example, if you have a high nephrometric score, for example, in case of a large endophytic tumor located in the interpolar region and it has a close proximity or invading the central sinus, it's more difficult to resect. You also prefer radical nephrometry. That's a more of a medium nephrometric score. It's basically the same findings that we discussed earlier. So to quickly brush up on what we just did, the essentials have to be in our mind. The size of the mass, the orthogonal dimensions, that is to have the staging and also guide the management of the lesion. And also this is a baseline, so we can follow up these patients and evaluate response. The mass type, presence of cystic component. So cystic is cystic mass of anything which has more than 75% non-cancer component. And it is important to mention this because cystic lesions are less likely to be malignant as compared to solid lesions. And also among malignant lesions, it has cystic component, they tend to behave less aggressive than malignant ones. That's the importance of mentioning the mass type. The macroscopic fat, these are areas in the non-contrasting and CT that must be built up less than 10. And especially the classification, if there is macroscopic fat, then most likely we are seeing an angiomyolipoma in the mass. And again, the fourth important or the essential element of our report should be the enhancement of the mass. Basically, an increase of more than 20 on-screen units is considered positive for enhancement or as enhancement. And this again, ideally, the number should be mentioned. Now moving on to other urinary urinary cancers. First one to begin with the lower urinary tract lesion, the bladder tumors. So what needs to be in the report is the primary tumor description, extent, location, size, multiplicity. As is known, it's usually an MRI, microscopy ultrasound that play a major role here than the CT. And again, due to that, the role of PET CT is also limited. However, we come in the picture for lymph node evaluation. So lymph nodes, you have this location and size, whether below or above the bifurcation. Involvement of the kidneys, presence of absence of hydronephrosis, hydronephrosis, and identify filling defects. Yeah. This is where the CT has shown its progress over CT alone, but then even small nodes which do not satisfy the criteria for significance may be intensely indicating the possibility of metastatic involvement. Coming to upper urinary tract lesion, again, description of the primary tumor, the location, renal calyx, of the location, either the renal calyx or the proximal mid or distal ureter, the extent, the intrauterine as well as the extrauterine extent of the lesion, distortion of the renal parenchyma, whether the gelatinous fascia has been disrupted by the mass, multiplicity of the tumor, and associated hydronephrosis. Presence of lymph nodes, the location and size of the lymph nodes that we mentioned, and metastatic evaluation. Involvement in this kidney, lower urinary tract, viscera, bone, again, it's a symptomatic and the evaluation. So, quite quickly, presently, MDG is not routinely recommended in the evaluation of follow-up of urinary tract tumors. PET-CT imaging should help it to have the measurement of the lesion, the size, the type of the lesion, the enhancement pattern, visualize the landmarks of staging, and identify neural and distal metastasis, especially in case of neural masses. And as far as surveillance or follow-up of lesions are concerned, especially in patients who are on systemic therapy, it's It's nice to remember this acronym MASS. MASS basically stands for morphology, abbreviation, size, and statistics. These are the findings that have to be mentioned in the report, and also the change in them compared to the prior imaging needs to be a part of the. And newer vaccine cases, gallium 68 PSMA, gallium PAPI, I'm sure this will be discussed extensively in the upcoming talks. So they indicate that there may be a larger role for PET-CT in the future as far as renal and renal tumors are concerned. We need to be ready with that. I wind up here and I thank you all for your time. Thank you so much.
Unfortunately, Dr. Harish can't hear me today, but he deserves all the accolades for this wonderful presentation on a not so easy topic, the genitourinary system, because FDG is usually excreted physiologically through the urinary system only. So there are many chances of misses here. And one thing which I may add is that we are usually not referred for characterization of uh, renal cysts because most of the time we see these cysts incidentally in images in scans which are done for some other indications. So in those cases, if we are routinely giving contrast to our patients, we usually do not have a pre-contrast image. And if we do find a cyst which seems to be complicated, we should not hesitate in recommending for a separate contrast PT for characterization of those cysts.
Totally agree with you, Dr. Abhinav. So we quickly move on to our next talk. I would request Dr. Archie Agrawal, Professor Nuclear Medicine and Molecular Imaging at Tata Memorial Hospital, on bed-based response assessment in solid tumors. And a very good morning to all of you. At the outset, I would like to thank Swagat, Dr. Partha, and the entire team of ANMPICON for inviting me here and having this wonderfully organized conference. So today I'll be speaking on PET-based response assessment in solid tumors. And in this lecture, we are going to look at why do we need PET-based response, and overview on PERSIST criteria, and then we move on to immunotherapy, the patterns of immunotherapy response, adverse effects that are related to immunotherapy, and there are multiple PET-based response criteria that have come up for immunotherapy, and which one do we use. So, this is the functional changes will precede the morphological changes, and that's the reason why we need to use PERSIST. Additionally, tumors might have lesions that are pleural effusion and lymph nodes with a short axis diameter of less than 15 mm. These are considered as non-measurable. Now, even though these lesions are non-measurable and they cannot be thus compared with RECIST 1.1, and thus the accuracy of response assessment may be limited, particularly in diseases which have predominantly ascites or pleural effusion or these small lymph node disease. So coming to PERSIST 1.0, this is more relevant than anatomical criteria when we are using cytostatic chemotherapies. It is more predictive of outcomes than the morphological criteria. So what is required in a baseline PET-CT study in PERSIST 1.0? You need a measurement of a single hottest tumor. So what you should remember is when you are doing a RECIST 1.1, cumbersome, you have to look at 5 lesions. Here you just have to look at one single hottest lesion that is there in the entire scan. The background is usually the liver, and how you calculate the background for the liver that we are going to see in the subsequent slides. And here, instead of doing the SUV max that we calculate, most of the times when we are reporting here, you look at the SUV values that are corrected for lean body mass and calculate the SUL peak. So now, what are the advantages of using the SUL peak? This is more consistent across variations in body mass. So whenever a patient receives chemotherapy and there is reduction in body weight, this becomes more relevant and is also subject to less variability than a single pixel SUV max, which is more susceptible to noise. And that's why SUL peak has been used in PERSIST 1.0. So what do we need when we are looking at PERSIST? So which SUV value? The SUL peak has to be measured. What is the measurable lesion? Now, whichever is the hottest tumor, the minimum uptake that is required in that hottest tumor is 1.5 times the liver mean SUL plus 2 standard deviations. Now, if the liver is diseased, then you don't look at the background liver uptake, but you look at the blood pool activity, which you measure in the descending iota, in the mediastinal descending iota. And how you are going to place the ROI in the subsequent slides we are going to see. Now, what ROI? The lesion, on the lesion, the size of the ROI should be 1.2 centimeters in diameter. And wherever you have the maximum activity, that is the place where you have to place this ROI. So if you have a central necrosis, you're not going to place your ROI in the central necrotic area, but at the periphery where you have the most highest HUV value that you are getting. Number of lesions, it's only one for, I mean, that's really easy, otherwise you have to, like there are many criteria which had 10 earlier, and that's why resist 1.1 came, you have 5 lesions only. So it's 5, it's 1 lesion here. And how do we calculate the percentage uptake? You look at the follow-up SULP minus the baseline divided by the baseline SULP into 100. So how do you calculate the background activity? You place an ROI 3 centimeters in diameter in the right lobe of the liver between the inferior border and the dome of the liver. And this, when you're placing this ROI, you should avoid the central ducts, the biliary ducts, and also the vessels. So this is the place where you should be placing the ROI when you are looking at liver background. Now, whenever the liver is diseased, you don't place your ROI here. You place it in the media. You are looking at the mediastinal pool there. So then you place your ROI. It should be 1 centimeter in diameter, 2 centimeters in length, placed in the center of the iota. You should avoid the vessels because the vessel wall because that might be inflamed and that will contribute to your SUL. So therefore, you should avoid the walls because there might be some amount of inflammation in the walls of the aorta. And when you're looking at mediastinal blood pool activity, it should be 2 times the background in the descending iota. Now, if this is not matching, then this is not your measurable lesion and you can't do your response assessment with PERSIST. Then you have to use RESIST. So in the follow-up study, now you have to select the hottest tumor at each time point. Another thing that you should remember. Now, there may be a lesion in the liver that you are considering when you have first that was the hottest lesion. So you are considering in the baseline study, you are considering a lesion in the liver. But when you are looking at a follow-up study and you have the hottest lesion in the lung, then you have to consider the lung as the hottest lesion, and that is the lesion that you're going to measure. So you have to remember that the target lesion selected at the baseline may not be the hottest tumor on the follow-up imaging. To show you an example, now this is the case of sarcoma with multiple metastasis, and this doesn't work, the cursor doesn't work. Okay, so this is the right lower paratracheal node, and you see that this has the maximum SUV when you're doing the baseline study, follow-up study. So, and how are you going to look at the percentage change in the target lesion? It's calculated as follow-up SUL peak in the target lesion minus the baseline SUL peak in the target lesion divided by the baseline SUL peak into 100, and you're going to arrive at the percentage change. Now, what is the criteria for treatment response? Complete response, we all know, and visual disappearance of all metabolically active tumors. So, don't now look at the SUV because your SUV will never be 0. We know that there's always a background activity. Visually, you should not have any activity in that area, and then it is complete response. Partial response, when you have a SUL decrease more than 30% or more than 0.8 units. Your progressive disease, when you have SUL increase more than 30% or more than 0.8 units, or you have a new lesions. And if it doesn't fall in any of these categories, then it is stable response. So from there, we move on to immunotherapy response assessment. And we all know that immunotherapy involves the use of agents that manipulate the components of immune system to cause an anti-cancer effect. And broadly, this includes immunomodulators, which we are dealing with every day, the targeted monoclonal antibodies, the CAR T therapy is also a type of immunotherapy, and cancer vaccines like BCG that is used in urinary bladder cancers. So when we are looking at immune checkpoint inhibitors, they commonly target the CTLA4, the PD-1, and the anti-PD-L1, which CTLA4 it's more dominant at the lymph node level, and the PD is mainly seen at the tumor sites. So the various types of immunotherapy response, it might lead to size reduction, but you may also see cystic change or a cavitation, intratumoral hemorrhage, or reduction in vascularity without a change in size. And because of these distinct responses, immunotherapy response assessment is different from what we see or what we do in normal chemotherapy agents. So this leads to a distinct pattern of response, which can be seen on FDG PET-CT images. And what are these distinct patterns of responses? So these unusual patterns of it is pseudoprogression. Another scenario where you can have multiple new lesions that come up. The blue ones are the new lesions that come up, but all will decrease. The ones that were pre-existing and the new will all decrease in the time point 2, and then it is pseudoprogression. So basically, you often see this pseudoprogression with symptomatic improvement in a patient and with subsequent reduction in tumor burden. This is pseudoprogression. Now, pseudoprogression, it is seen in less than 10% when we are using combination therapy. So when we are using both CTL4 and PD, then it's seen in less than 10% of the patients. It's not very common as much as we think. So pseudoprogression is not as common as what you see in hyperprogression. And a reassessment PET-CT should be performed at 4 to 8 weeks to confirm pseudoprogression or pre-progression. So coming to hyperprogression, this is rapid increase in size, FDG activity, and appearance of new lesions in a clinically deteriorating progression. This defines hyperprogression. So this is more common than your pseudoprogression. This is seen in less than 30% of the patients on immunotherapy, and it requires immediate cessation of these drugs and switch to alternative chemotherapeutic agents. Now, there are multiple criteria for defining hyperprogression, but nothing is sacrosanct. So, some of the things that have been utilized is time to treatment failure of less than 2 months, greater than 50% increase in tumor burden, and greater than 2-fold increase in the pace of progression. So if you see this example, 80-year-old male, a case of clear cell RCC, this is the baseline FDG PET-CT study of progression. But here, because the patient was clinically deteriorating, the immunotherapy was stopped. But otherwise, you have to do, the patient is still okay and not deteriorating clinically, then you have to do a repeat imaging at 4 to 8 weeks. Coming to dissociated, here some lesions will respond, some will not. That is because of development of resistance because of genetic mutations. And this we can easily see with FDG because you will see some lesions which are not responding and some new lesions which will be coming up. So from this we move on to the immune-related adverse events. Now this is also important because here immunotherapy uses patient's immune system to fight against tumor cells, and this increased immune activity will activate the T immune cells in a variety of normal tissue, leading to autoimmune side effects which are known as immune-related adverse effects. Now these are usually mild, sometimes severe, and rarely life-threatening. These should be reported, and many a times we'll be seeing thyroiditis, colitis, pneumonitis on our scans, and this have to be reported. They should be reported, though not necessarily associated with the clinical symptoms. Now, the frequency of these adverse effects, it varies as the type of the immunotherapeutic agent used. It is also dose dependent, and if you are using the CTL4 agents, these will cause more immune-related adverse effects. But if you are using a combination, so is there an association? Because so is there an association between these adverse effects and tumor response to multiple articles, and they have been looking at that, whether there is, when you see these immunotherapy drugs, such as the greater the immune response, it leads to more effective anti-tumor activity. But 2 minutes more was okay. So because of this autoimmunity, and however, but if the drugs are continued, then it may lead to toxicity. So these are the some of the immune adverse events that we can see. That's pneumonitis, hepatitis, hypophysitis, colitis. These can be visualized, and many other which you don't visualize on your FDG PET image. From there, we move on to the PET-based immunotherapy response criteria. Now there are multiple. There are few of which will only use the pure PET-based response criteria, which are the I-PERSIST, IM-PERSIST. Then there are few PET. Excuse me, please. You're disturbing. PET-CT-based response criteria, which is PERCRIT and PERSCRIPT. So if you look at the PET-based response criteria, the I-PERSIST, this is very similar to what we use in I-RECIST. It has the same PERSIST criteria, plus you have the unconfirmed and the confirmed progressive disease evaluation. Whereas in ANMPICON. Now, I said that in persons, you are always using one lesion, but this ANMPICON is a 5-point analysis, and you have to measure 5 lesions in it. PET-CT based response criteria per crit and per looks at the resist, also includes the resist, which is more than lesion or a diameter of more than 5 mm.